Okay, I'm back again, and this is a continuation of our ECG time. Let's take a break. Okay, this is about inferolateral STEMI. So what will RNs do when the patient arrives in CCU post-STEMI with PCI or stent insertion? Okay, we will do a continuous full system assessment, not only cardiac, like neuro, pulmonary, renal, vascular, and so on. There will be a continuous cardiac monitoring. We will watch for the following, problems that will possibly happen or not. Number one is instant restenosis. Be sure that our stent is not going to block. If ever the stent is blocked, which is rare to happen, or instant restenosis, the ECG will show and the patient will complain of chest pain. Okay, arrhythmias. We have friendly arrhythmias and we can have also bad arrhythmias. So reperfusion are benign or friendly arrhythmias that you see after the stent is inserted. Okay, like for instance, when the patient came, he was actually in sinus rhythm, like in about 62. And here he was a little bit brady, like 58. And then this is our first reperfusion arrhythmias. We have the short run of VTAC. The patient is nothing. It's like uneventful or just asymptomatic. And there is an episode of like a pause with it. And then went to sinus rhythm. Okay, and next, the heart rate starts to speed up a little bit, sinus tachy. That is our next reperfusion arrhythmia. To the point that it became SVT. Okay, that's another reperfusion. Okay, and then went to a pause like probably 3 seconds or 3 to 0.5, something like that. Okay, we have a sinus exit block in here. So normally there should be, the sinus node should have emitted an electric impulse there, but not. So that is only one bit, so I consider that sinus exit block. And then again here, it start to operate again. And then one sinus brady, and then back to sinus rhythm. And there's another burst of SVT again, which is another reperfusion. So reperfusion arrhythmias are friendly. It's true, they're benign. Okay, and some say it could be caused by automaticity. It could be caused by automaticity from the ventricle side or from the atrial side. Okay, and it could be also the ionic exchange. Okay, it could be also related to some radicals or anything. They have several theories about reperfusion arrhythmias, but for my observation, based on my observation, I noticed that they are friendly and we don't suppress them if they're short run. Okay, coping mechanism so far. So we have here a short run VTAC, then we have a sinus tachy to SVT to sinus pause, brady, sinus brady, and then to SVT again. So one thing that the nurse can do in here is just be sure that your bladders are okay. So we'll make our, the environment of our heart muscle and our, conductive system okay, is to have a good or normal electrolytes. Example, our potassium is okay, our magnesium is okay, our lungs are clear, we don't have any chest pain, we sats okay. We'll make the environment okay so that we don't, because you'll never know if this run of VTAC will be longer. One cardiologist say that don't take it for granted. It could be a real VTAC and it could be a re-entry VTAC. So just to be sure, yes, reperfusion is benign, but just to be sure that your electrolytes are okay and your patient is dry, okay, and there's no existing problem, desaturation or chest pain or anything, okay. And renal perfusion. So that's it. Now, arrhythmias. CHF is another one that we will watch post-procedure. We have our heart. The heart became weak after the STEMI, of course. It's like having a flu. You feel weak and you want to rest. So in this case, be sure that the heart is not overworking after the procedure because there might be a problem. So in here, when you have a congestive heart failure in here, the patient will manifest wet lungs, short of breath, or they could desaturate, okay? And they can go tachycardia. So we notice when they go tachycardia, you are overworking your heart. There is a reason, okay? It could be your lungs are wet. So we deal with the problem. Bleeding is another concern post-stent insertion. So you might be bleeding inside, you develop hematoma in the hand, if it is radial approach, or to the groin, if it is femoral artery approach. Okay, so you develop hematoma, or you could be bleeding externally and blood is coming out arterially. Okay, so you get wet with that. And there's another bleeding that we don't see and we don't feel, but there are parameters that will go down. Patient will be pale, become bradycardic or hypertensive because we have a retroperitoneal bleed. So we do stat blood works. Okay, our pulses might be absent. So be sure that there's no clot sitting in the radial artery or in the femoral artery. So if it is a femoral approach, then you might lose your dorsalis pedis or your posterior tibialis pulses, or it could be from your hand. You lose your, radial or ulnar pulses. There could be a clot sitting there and you see the color is a little bit, bluish or anything. So pulseless, bluish or anything is a sign that there might be clot sitting in the nearby artery. Okay, so we keep an eye on those. Checking blood works, I mentioned that already. And then also medications. We will start the medication as soon as possible when the patient arrives. It depends. Okay, now antiplatelets medication here. Usually the aspirin is already given by the ALS or the 911 crew. If it is ordered Plavix or ticagrelor, that will be given in emerge or in the cath lab before, angiogram. Okay, the beta blockers, we normally give this if the patient's heart rate is above 50 and the blood pressure is above 90 or either one. And these beta blockers, this gives us a negative inotrope. So we don't want to let the heart muscle work harder. And also it has something to do with some automaticity. Okay, ACE inhibitor is also helpful, keeping your pressure okay, because these both beta blockers and ACE inhibitors are both anti-failure. So in this case, we don't want the heart muscle to work harder. So we tone down by giving them beta blocker and ACE inhibitors. So both are anti-failure medications, but there are precautions to be observed, and that has to be held, or there is a specified order by the doctor, just like the beta blocker. Okay, statin. And by the way, you don't give beta blockers if the patient is in heart failure. Okay, wait till they're cleared up and you start giving it. Statin. Statin is to protect the coronary arteries. So this is to, this is an anti-inflammatory and to protect the patient from bad cholesterol, the LDL, or the buildup more. When you have an MI, you have a buildup of lots of fatty acids actually, because during ischemia, okay, so you go into anaerobic metabolism, so fatty acids will not be used up because fatty acids is the first energy of the heart muscle. So in that case, if it is not being used up because there's not enough oxygen, there's be a lot of fatty acids floating in the system. So statin is an anti-inflammatory and anti-bad cholesterol or the LDL. Okay, so we have seen the progress of the patient from having an ST, elevation MI, from being saved by a stent insertion, and then we have a positive reperfusion arrhythmias, which is a success. And then here, one day after, you notice now that you are seeing a progressive and maintained isoelectric ST segment. The P waves are starting to show up in our inferior leads and so in our lateral leads. Okay, so what happened is here is that the wife reported the